We're talking about really focused on children who were diagnosed with acute lymphoblastic leukemia, which is the most common pediatric cancer. And we know that while we have exceptional cure rates for pediatric ALL, that successful treatment right now still requires over 2 years of multi-agent chemotherapy. And that likely produces a lot of financial burden on families. There are estimates of over 200 outpatient visits, 40 inpatient days, and that can lead to a lot of disruption to a family's day-to-day life, and both direct costs of transportation, childcare, as well as indirect costs of having to take time off work or even having a caregiver quit a job. And so that all amounts to something called financial toxicity, which was the focus of this study, in which we looked at over 400 families of children with pediatric ALL who were enrolled on a clinical trial. And during that time, their caregivers filled out 4 different surveys throughout the course of therapy. And what we sought to measure was the proportion of families who were developing new household material hardship or income loss. Household material hardship is something you can think of as difficulty meeting your basic living needs. So things like housing, food, or utilities, and security.
It's absolutely surmountable, including these shocking data. But to your question of where these children were, so this study was conducted among children with ALL enrolled on the Dana-Farber Cancer Institute ALL Consortium trial 16001. And that is a clinical trial that is run across 8 U.S. and Canadian centers. Kids who are enrolled in clinical trials in the northeastern United States in particular may in fact be coming from families with more resources than those kind of across the broader United States. When we think about the applicability to other nations or other healthcare systems, I think there's a lot of direct relevance. We hope that some of those other healthcare systems may buffer some of this financial toxicity more than what we see in the United States. But the concept of parents being asked or not being asked, parents choosing to be at their child's bedside in the hospital while they're getting chemotherapy, or choosing to bring their child to clinic so they can get the chemotherapy to cure their cancer, it's not really a choice, and parents do whatever it is we tell them is going to be necessary to give their child a chance of cure, and you cannot be working at the same time that you're doing that. And so this construct of there being profound financial burden on families, I think applies across all systems.
So, I think our main finding really was that a striking number of families develop new household material hardship or catastrophic income loss over the 2 years of their child's cancer chemotherapy. So what we found was that nearly a third of families in the study by 24 months had developed one of those 2 outcomes. And that includes 1 in 4 families who had no signs of household material hardship at diagnosis. So meaning, they came into treatment without these, markers of financial struggle and went on to develop these new difficulties meeting basic living needs over the course of therapy.
I think these data should be shocking to us as clinicians and as parents and as people who support people going through medical complexity. The fact that we now have data that show that 1 in 4 children being treated for the most common childhood cancer is living in a home that is worried about putting food on the table or having a roof over their head because of the financial burden of therapy is completely unacceptable. And I think at the same time, that's actually incredibly exciting, because now that we have those data, that allows us to actually do something about it, to begin saying this is a problem and this is something that we need to intervene on. And so to your question of what we do, the scientific answer is we don't actually know what the right intervention is. We don't know how to cure financial toxicity, although I'll say confidently, if we can figure out how to cure childhood cancer, we can absolutely figure out how to cure financial toxicity. We are trialing one approach in the next Dana-Farber ALL Consortium trial, 25001, that will be opening in the early winter of 2026. And that clinical trial will also be run in the northeastern United States and Canada. And that trial is going to include an embedded randomized controlled trial evaluating a cash support intervention called RISE for low-income families to see if we can mitigate financial toxicity as well as improve other parent and child-centered outcomes.
I think there are examples of other things that have either been trialed in the adult oncology space or also, starting to be piloted in the pediatric space. There are other sort of resource-directed provisions like cash transfers. So, Dr. Bona has previously led a study looking at more directed grocery and transportation support for families. That's one, option that is also direct resource. And then there are other sort of more informational-based strategies. So linking families to financial or resource navigators, and whether that is globally, like how you manage finances, or specifically regards to managing insurance, for instance, is one approach that has been trialed and studied in the adult oncology space. I mean, I would definitely say that this is an important outcome. This is an important patient and family centered outcome. I think one of the reasons that we are uniquely poised in pediatric oncology to start to address this is that our survival rates for pediatric cancer and pediatric ALL are actually very good. And, what that pushes us to is, what is the, ultimate type of outcome that we are, that we're moving towards. Survival can't be the bare minimum of that is the only thing that we're focused on. We have to think about the future that, we are giving to these children and to their families. And I think, financial security should be part of that. Like, the choice shouldn't be, do I cure my child's cancer or go bankrupt? Like, that's a false dichotomy that I don't think families should have to choose.
I'll simply echo that to say, I think these data are incredibly important for exactly that same reason. Perhaps slightly more simply, our goal is to cure every child of cancer. And in ALL, that means that you're talking perhaps about a 5-year-old child. And that 5-year-old child, when they finish chemotherapy, needs to have a house to go home to, and they need to have food on the table. And if we fail to accomplish that as the clinicians and society supporting them through that, then the concept of why we've bothered curing their cancer does come a little into question. And I think as a society, I think for every parent thinking about their child having cancer and going through treatment, we can very easily say to one another, it's not acceptable for parents to be worried about feeding their children while they're getting chemotherapy. That is not, in fact, what we across the United States are looking to do with childhood cancer. And I think that we can all agree that, in fact, doing a better job of making sure that parents can be focused on getting their child through incredibly toxic chemotherapy, helping their child to manage the emotional stress of going through a cancer diagnosis and treatment should be their focus. We ask that of them. Every parent steps up to the plate and makes that happen, and we can figure out better ways to support them.